So in the previous video, I talked about endometriosis, and this occurs when we have endometrial tissue or the inner lining of the uterus being found somewhere outside of the uterus. Now, we have a condition called adenomyosis, and this is a sister condition to endometriosis, but it is thought of to occur or to be caused by slightly different mechanisms, and the theories are going to be slightly different. But just like endometriosis, the understanding of adenomyosis is still poor, and it's going to occur when you have endometrial glands and stroma inside of the myometrium. So in endometriosis, the tissue is outside of the uterus, but this time in adenomyosis, we are having endometrial tissue occurring within the muscle of the uterus. So if you look at the uterus, it has a serosa, which is the outer lining. It has the myometrium, which is the muscular layer, the one that enables it to contract and to relax. And then we have the inner layer, which is the endometrium. And this endometrium plays various roles during implantation. It's the one that first feeds that embryo before the placenta is formed and things like that. And even when the placenta is formed, the endometrium is kind of the interface that connects the placenta to the maternal circulation, so it's a bit soft and things like that. So what happens is that when you have this endometrial tissue occurring within the muscle, we are going to have cyclic bleeding, and that bleeding is going to occur within the muscle because as the hormones fluctuate throughout the cycle, we are going to have the endometrial tissue in the muscle growing bigger and smaller, and it's going to be bleeding but inside the muscle, and that is going to cause a lot of inflammation. It's going to cause myometrial hypertrophy, which is growth of that area of the myometrium, and that leads to a bulky and a tender uterus. So the classic triad, the woman is going to come in, they're going to complain that they're having very heavy menstrual bleeding, they're having progressive dysmenorrhea, so with every subsequent period, the pain increases, and then they're going to have a bulky and tender globular uterus. So the uterus is going to increase in size. If you take a sneak peek at these images, this is an understanding of what's actually happening. These dark spots, the brown spots, are the endometrial tissue, and they are found within the muscle, and during the cycle, they can increase in size, bleed within the muscle, cause a lot of pain and things like that, and lead to the heavy menstrual bleeding. And as you have seen, the muscle is going to hypertrophy and increase in size, so the uterus is going to increase in size. And sometimes when you try to examine it, it may feel like maybe an 8 to 12 week uterus would be if it was gravid or if there was a fetus. So the epidemiology, it's common in 35 to 50-year-old women, and it is usually in multiparous women. Nowadays, it is usually seen in younger or infertility patients, and it often coexists with fibroids, endometriosis, and polyps. Now in the next video, we're going to look at fibroids, and we shall look at the different aspects of the condition, and you will realize that fibroids are going to have a very similar presentation to this adenomyosis in terms of the bleeding, in terms of the uterine increase in size, and we are going to look at how we can differentiate it from the adenomyosis. So we'll look at the risk factors that have been implicated. Multiparity is one of them, having very many children. We think that this repeated trauma to the endometrial layer can cause the endometrium to leak into the myometrium because there's disruption of that basal layer. Then previous uterine surgeries like cesarean section, D&C, and myomectomy are thought to cause also a disruption in the myometrium as well as the endometrium, so they destroy that interface, and one leaks into the other, the endometrium ends up leaking into the myometrium. So endometriosis is a risk factor for adenomyosis. Then fibroids, high estrogen exposure, tamoxifen, obesity, early menarche, as well as short cycles. So the pathophysiology of what happens is that we have a junctional zone. This is the basal the area between the endometrium and the myometrium. For some reason, the basal endometrium, the inner layer, goes on and invades the myometrium, and this ectopic tissue starts to bleed cyclically, like it would when it was in the uterus. We know that the endometrium is developed throughout the cycle, and then it is shed during the period. So The ectopic tissue is going to behave like that, but this time it is inside the muscle, and that is going to cause inflammation and prostaglandin release. And when this occurs, the smooth muscle of the uterus is going to hypertrophy, and we have an enlarged, painful uterus. So when we look at the types, we have the diffuse type where the whole uterus, and this is going to cause a globular enlargement. Sometimes you may think it's an early pregnancy, especially if you don't have the history very well, or if you don't come in with the complaints of the pain and the bleeding, and routinely it may feel like a cleft uterus. Then we have the focal type where it's localized, and this one is the one that we're most likely going to confuse with the fibroid. We have an adenomyoma, and then we have the cystic, and sometimes we have the hemorrhagic cystic spaces, and this is going to be having severe pain. So this is an image trying to show some of these different parts. As you can see, this is a focal, this is a diffuse, and then we have the cystic around here. So clinical features, we have the symptoms, that is heavy menstrual bleeding. This is going to be the very common presentation. They're going to present with very heavy bleeding. Then they have progressive dysmenorrhea, and then we have chronic pelvic pain. We have this deep dyspareunia. This is pain during intercourse, intermenstrual bleeding, subfertility. So they're going to have fertility issues, and they're going to have miscarriages. They're going to have pelvic heaviness. They're going to have iron deficiency anemia because of this repeated bleeding. And then when you do the signs, you may see a bulky uterus on examination, a globular uterus, a tender uterus, and it's uniformly enlarged most of the time. And the size of the uterus is going to be around 8 to 12 weeks. So it's going to be still below the umbilicus, but a bit perceivable above that. So the differentials, the most top differential is the fibroids, and that one we're going to see how we can differentiate it. Endometriosis is going to be a common cause, endometrial polyp, endometrial hyperplasia, or cancer, because whenever you have bleeding in any woman, you want to rule out endometrial hyperplasia, and bleeding in any woman who is in menopause is endometrial cancer until you have proven it otherwise. Then we have pelvic inflammatory disease, we have pregnancy-related bleeding, we can have coagulopathy, thyroid disease, as well as cervical pathology. So when we look at the fibroid versus the adenomyosis, when you look at the uterus, in adenomyosis, most of the time there's a diffuse globular enlargement, while a fibroid is a single kind of tumor. It's this benign tumor that is going to enlarge, so you have an irregular or nodular uterus. Then when you look at the lesion of adenomyosis, it is poorly defined, but all fibroids are found to have a pseudocapsule around them, so they're going to be well circumscribed. And the capsule part is that in adenomyosis there's no capsule, while in fibroids you have the capsule. Then the pain, dysmenorrhea, is going to be very common in adenomyosis, while in fibroid it's more of a pressure and the heavy menstrual bleeding more common. So the imaging, you will see myometrosis, while imaging of the fibroid is going to just show a discrete mass. So investigations you can do a beta HCG to exclude pregnancy, full blood count for anemia, ferritin or iron for iron deficiency. We can do the thyroid stimulating hormone or coagulopathy if indicated. We can go ahead and do the pap smears and STIs if indicated, as well as do an endometrial biopsy, especially if the person is above 45 years. So whenever someone has 45 years or more and they have abnormal uterine bleeding, the first thing that you want to consider is going to be endometrial cancer, because it's the worst of the diagnosis, and work your way down the list. So intermenstrual bleeding, if they have obesity, PCOS, or they are using tamoxifen, all these increase the risk of endometrial cancer, and their failed treatment, as well as having risk factors for the cancer. So when you look at the imaging, the transvaginal ultrasound is going to be the first line, and when you do this, you're going to find a globular uterus, asymmetric myometrial thickening. So you're going to see areas of thickening of the myometrium. You're going to see myometrial cysts. You're going to see fan-shaped shadowing, hyperechoic islands. These are small areas which are going to be hyperechoic within the muscle. You're going to see regular junction zone and subendometrial lines. These are very important signs, and those are what you will look for to suspect if someone is having this adenomyosis. Then MRI can be done if the ultrasound is equivocal or it's not giving you something very concrete. Then if you also consider surgery or fertility planning, an MRI can improve on the amount of information you get. And this one, you're going to look at the junction zone thickening. If it's greater than 12 millimeters or if there is low T2 myometrial areas, high T2, T1 hemorrhagic foci, then a globular enlarged uterus, all these are going to point to you having adenomyosis. Then when you do the diagnosis, the diagnosis is going to be both clinical as well as imaging supported. So the strong clue is that if someone has been having heavy menstrual bleeding, progressive dysmenorrhea, and a bulky tender uterus, then you do the imaging and it shows those signs, then most likely you are going to be dealing with adenomyosis. The definitive is going to be on histology after hysterectomy, where you remove the uterus and you examine it and you find that there is that endometrial tissue in it. Then the management principles are going to depend on the age, the symptoms, the fertility desire. We have seen that the definitive test is the hysterectomy. You don't really want to go ahead and do a hysterectomy on someone who has not yet had children or wants to have children. The uterine size is going to be an issue here. The focal versus diffuse disease, coexisting fibroids or endometriosis, and the need for contraception. So when you look at the medical management, there's the pain dominant management and the bleeding dominant management. Some are going to have more pain and some are going to have more bleeding. So when you're dealing with the pain, you want to give NSAIDs, and this will reduce the prostaglandins that cause the uterine contractions. And sometimes we do the continuous combined oral contraceptive pills, the COCPs, and these ones are we can do the oral or the depot progestins, and sometimes the levonorgestrel intrauterine system, the IUD, can help reduce on these periods or prevent the person from entering periods. They initiate what we call a pseudo pregnancy. Yeah. Then short term, you can use a GnRH agonists. These ones are going to do what we call a medical oophorectomy. So you are kind of preventing the person from experiencing the normal fluctuations of hormones of the cycle. So they are not going to have the normal menstrual cycle or the bleeding, and that means they are going to avoid the pain. So the bleeding dominant, you want to exclude pregnancy as well as you want to exclude cancer. This is someone who's not waiting for their period. They're having heavy menstrual bleeding, they're having intermenstrual bleeding, they're having bleeding at any time. And then you want to correct the anemia, and the levonorgestrel IUD is the first line, because once you put it in there, it's going to stop the person from having periods, and when they don't have periods, they're not going to lose blood. So to prevent them from developing the anemia, you want to stop them from having their period as normal. Then you can give tranexamic acid and NSAIDs during the menses. So the tranexamic acid is going to help with stabilizing the clots, and that is going to reduce on the bleeding from the adenomyosis, and that is going to help prevent the anemia. Then the combined oral contraceptive pills and cyclic progestins are also going to do the same things. And then some specialist procedures are done if this fails. So in the drug options, you have the NSAIDs, you have the tranexamic, you have the levonorgestrel intrauterine system, you have the COCPs, you have the progestins or the DMPA. These are progesterone based and birth control pills, the GnRH agonists, and then the aromatase inhibitors. These are going to reduce estrogen, because you know estrogen is one of the hormones that are important in the development of the endometrium. So without estrogen, the endometrium is not going to grow, and then you won't have the pain and the bleeding. So some procedures that are done, things like endometrial ablation, especially if there is heavy menstrual bleeding, and fertility is complete. So if you want someone who's going to give birth, then you don't want to do endometrial ablation. Sometimes they do the uterine artery embolization, that is uterus sparing. So you embolize the uterine artery, and this is useful especially in people with fibroids, because now if they have fibroids and adenomyosis and you embolize the artery, both of those are going to be managed the same way. Then we have some other tests like HIFU and RIFA, and these ones target the focal disease. We have adenomyomectomy, which is where you go and remove a focal disease, you remove it. But the problem is it's difficult, really. Remember, unlike fibroids, adenomyosis does not form a capsule, so it is a very difficult procedure. And as you remove that focal disease, you may actually perforate the uterus and have uterine rupture. or the risk of uterine rupture increasing with subsequent pregnancy. Then hysterectomy is the definitive chew-up, especially if someone has completed a family. Then you want to remove the uterus so that they don't not continue to have this pain. So if they want fertility desires, you want to avoid hysterectomy, you want to avoid endometrial ablation, and you want to consider giving tranexamic acid, NSAIDs, and MRI mapping and treat fibroids, stroke, endometriosis, and other fertility issues that could be associated with this. And then you can do conservative surgery if there is focal disease. And another thing you have to consider is if someone is trying to get pregnant, you don't want to put them on the oral contraceptive pills. So the complications during pregnancy are generally you want to give the iron deficiency, you want to treat the iron deficiency anemia. They may have chronic pelvic pain, severe dysmenorrhea, dyspareunia. They may have fertility issues. Miscarriages are common because once the uterus is disturbed, the architecture of the uterus is disturbed, then the risk of miscarriage is going to increase. The reduced quality of life, recurrence of conservative therapy, and things like that. So pregnancy associations, there is miscarriage, preterm birth, fetal growth restriction, malpresentation, placenta disorders, and cesarean delivery. So we've come to the end of this video. I hope you enjoyed it. If you didn't watch the video on endometriosis, please try to watch it. My name is Benjamin, and have a nice day. This is Med1Pager. Let's meet in the next video. Don't forget to check out www.med1pager.com where you can download the summary free and also try out a quiz of up to 20 questions from this particular topic.